Here we go. We're live. It's happening. We're
Yay.
here again. Happy Monday, everybody. I have another wonderful guest. We have Tatyana. I will let her introduce herself, but we're so lucky to have her. We did a really awesome live together I want to say it was weeks ago, but it was probably more like months at this point.
Who can tell?
Yeah, my gosh, especially when we both have toddlers. Time early goes by really quickly and also really slowly at the same time. So, guys, yeah, we have her here. OCD expert. She's really good. She's really amazing at everything that she does. So I'm going to let you introduce yourself, Tatyana, and then we'll get into question and answer.
Awesome. Well, thank you so much for that beautiful introduction. I'm Dr. Tatyana Mestechkina. I'm a licensed clinical psychologist. I'm the founder and the clinical director at CBT for Better Living, where we specialize in treating OCD and related disorders, as well as all types of anxiety disorders, some perfectionism, body image concerns. And we are seeing patients in New York, New Jersey, and Florida.
Awesome. Yeah, that's right. And we sometimes get questions about things that are kind of related to OCD, like generalized anxiety disorder or body concerns. So it'll be really good to have your feedback on that too. So all right, let's just get into it. So for those of you who don't know me, I've been doing the Monday webinars for a while, but my name is Jenna Overbaugh. I am a full-time therapist here at NoCD. I've been working with people who have OCD and anxiety for past 10 or 12 years. I've been at Johns Hopkins, been at Rogers Memorial Hospital here in Wisconsin, and now I'm at NoCD. So super happy to be here and get you guys an hour of good question answering, but not reassurance. We talked beforehand. We're going to try really hard not to do that. Alrighty. So yeah, you guys will notice we try to pick questions that are generalizable to everybody and could apply to a lot of people. Awesome. This is a really good question. So from Josh, I've made a lot of good progress as I near the end of my weekly treatment phase with NoCD. Awesome job, Josh. Do you have any recommendations for pushing through combating the remaining pieces of a few obsessions? Well, first of all, I think that's awesome, right? I think that you are kind of in the home stretch. You've obviously done the work in trying to get in a good therapy program with a good ERP, specialized treatment setting. So that's really the best and most important step. As you go towards the end here, I would really just remind yourself, like, what is this all about? Like, why am I intentionally making myself feel this way? Why have I been doing this hard stuff this whole entire time? I guess my advice would be to really hone in on your why, and really realize that your OCD doesn't have anything to do with content, especially in this end game here. As you're in the home stretch, just realizing truly like the big picture, like really realizing that, yes, you're doing these exposures. Yes, you're resisting these rituals. You're doing the 10 out of 10s on your hierarchy or whatever they might be. But really it's about getting your life back. It's about you being back in the driver's seat. It's about you being able to make decisions for yourself and not your OCD. So I guess my best advice and my recommendation would be to keep the big picture in mind and just come back to your why and remember like what this is all about. I'll try to keep thinking of some maybe like practical tips, but Tatyana, I'll give it to you really quick in case you have any recommendations, and I'll see if I can come up with anything else.
Sure, because I love everything that you said, Jenna, right on point. And the only thing I'd add to that is really being mindful of how you measure success. So it's very common for people when they get further into their treatment to experience less intrusive thoughts and anxiety. And while that could be awesome to enjoy by all means, and often is what happens, that is not how we want to measure success, right? We want to measure success not by the anxiety and the intrusive thoughts going away, even though that's really nice and enjoyable when that happens, but on your ability to consistently treat them as irrelevant. So I think just reminding yourself that even if the thoughts are still there or come up frequently, or a new theme even comes up, that does not necessarily mean you're not progressing. That doesn't even mean that you're going forward. That again, the goal of the therapy is to treat any red flags of OCD as irrelevant, which is also, I think, related to the talk that we had previously on Instagram for how the content doesn't matter. And the other thought that I had on that question is that it's important to continue to be proactive. It's very easy for a lot of patients to be like, oh, good, I did all this hard work. Now I'm reaping the benefits. OCD, goodbye. But you really get a lot of bang for your buck for your willingness to still be proactive, to still do exposures, even if you're not actively experiencing a lot of OCD episodes.
Mm-hmm. I love that. So good. So good. And I especially love you reminded me of the potential here for like the backdoor spike. Like how towards the end of treatment, it's very characteristic and very predictable, Josh. If you haven't already, just be on the lookout for OCD to try to, sabotage and potentially get in there when it comes to your progress. Like, I wouldn't be surprised if you or anyone else in this predicament of kind of nearing the end of treatment, having made a lot of good progress, if their OCD tends to flare up and have that intrusive thought, well, are you sure that you got better? Are you sure that you're ready to be done with your therapist? Are you sure that you know how to do this? Or kind of play that whack-a-mole game and try to like go to some other different subtype altogether. So I'm not saying that will 100% happen, but I would say that if it did happen, I 100% would not be surprised, because that's just a sneaky trick that the OCD tries to do, with it being the doubt disorder, so on and so forth. So, just be, have more of that like active stance. Like when that happens, when my OCD tries to negotiate my progress, I'm going to respond to it as though I would any other intrusive thought, using all the skills that I've learned through my experience with ERP. So yeah, hopefully that's quite a bit of practical tips. But
just a quick addition to that, sorry. Just a quick addition to the backdoor spike one. Another one that's sneaky one to look out for is like, oh, well, now that I'm getting this intrusive thought and maybe less anxiety or even no anxiety, this might mean this wasn't OCD after all. Real danger. So that's one of the oldest tricks in the book as well, related to the backdoor spike.
Yep. And these tricks are nasty, man, but they're predictable, right? It happens quite often. So really good tips, I think, for anyone out there who's nearing the end of therapy. That should be like its own Instagram live. Like towards the end of therapy, as all these doubts can start to come up, it can be a complicated time for sure. And OCD can really rob you of that celebration of being able to really acknowledge and get excited for all the things that you've done. So of course, OCD is going to try to sweep in and sabotage all of that. I think I have a good one for you. So we will get your thoughts on this for sure. So Jessica, I struggle with obsessions surrounding parts of my body, but I know I don't have BDD. It's so hard because I actually like how I look, but the OCD anxieties make self-confidence such a struggle. So yeah, so some of these comorbidities can really be overlapping, and it can be kind of difficult to tell, like, well, where does one end and where does one begin? What is OCD about my body versus body dysmorphic disorder or something else? And a lot of the times we'll look at the function of that behavior. So why are you doing that? So are you doing it to fulfill some type of uncertainty? Are you trying to do it because it just feels like if I don't, something bad will happen? And so, we look at a lot of these things like the function of the behavior. And so it's good that you have already tried to kind of tease that out. But yeah, I think when OCD attacks your body, just like anything, right? Like that can be really devastating. That can be really difficult. And it can make things hard. It can make the exposure work definitely hard when you're struggling with that self-confidence piece. But we would, whatever the obsession is about, whatever the compulsions are helping you kind of do, we would always apply ERP pretty similarly, right? So no matter what the obsessions have latched onto, it's always going to be ERP. We're always going to want to apply exposure and response prevention to that. So even though your exposures and your response prevention is going to be very tailored to your specific situation and for your specific triggers and your goals, we're going to apply the general structure of ERP to you and your obsessions the same way that we would to somebody who has something completely different, like contamination. So really working with a therapist who can help you identify those triggers, help you identify and do that like functional analysis of your compulsions and kind of the function behind why you're trying to do what you're doing, and gradually exposing you to these exposure-like situations, so that you can eventually habituate to those situations and also learn that I don't necessarily need to do X, Y, and Z in order to feel a certain way, or I don't need to feel a certain way in order to do this thing that I really want to do. Do you have any additional thoughts?
Yeah, no, I think that's great feedback. I think it's really tricky when it comes to anxiety in general. There's so much overlap with OCD, BDD, general anxiety, and then just life intrusive thoughts. And I think one of the really beautiful things about this kind of therapy, and one of the things that make me excited, is that when we work really hard initially of just applying ERP and ACT to OCD intrusive thoughts, and eventually when patients get the hang of it, they actually find themselves being able to apply these tools for things outside of OCD, because we all get intrusive thoughts. Our brains get stuck on anything and everything, people with and without OCD. And of course, body image is a really big part of that. Those thoughts are really common for, unfortunately, a lot of people, women and men as well. So a lot of learning how to identify unhelpful thoughts that are not in line with our values, and learning how to create separation from them, how to make them less powerful, how to make less decisions based on them, how to gain more freedom from those thoughts could be something that you could take from traditional ERP therapy and then generalize to just body image concerns, intrusive thoughts related to that as well.
Awesome. Yeah, when we this was for body dysmorphic disorder, but we would apply exposure and response prevention at least where I was at Rogers. I was at Rogers Memorial Hospital in the residential OCD and anxiety recovery center, and we got people with all kinds of different comorbidities, depression, different types of anxiety. Body dysmorphic disorder was definitely one of them, and we would apply ERP strategies to BDD as well. So infusing a little bit more maybe cognitive behavioral therapy techniques, just like thought challenging and stuff like that, than typically we would with more straightforward OCD, but still the same kind of meat and potatoes of it, right? Like approaching the things that you are afraid of and releasing and kind of getting rid of those safety behaviors that are actually maladaptive, but they seem helpful at the time.
Yeah, absolutely. There's so much parallels with the treatment between OCD and BDD. And I think for Jessica particularly, one thing that would be helpful would be really to, if you're not already, to work with a therapist that can help you better identify what these thoughts and feelings would conceptually be part of, which could then inform the best treatment moving forward.
Awesome. Wonderful. So this is one of my favorite topics. It's also like one of my most frustrating topics when it actually happens. So Dr. Tatyana, you have probably experienced this when people's OCD interferes with the treatment itself, like when they try to perfect the treatment, when they try to, like, they obsess about the rating scale or something like that. So Kendall asks, how do you continue to do exposures after therapy without becoming obsessed with doing exposures? So I posted something like this on my Instagram about how, I think what you're referring to, Kendall, is how, like, if you're compulsively doing exposures, then you're still doing a compulsion, right? So this concept that you're like, oh my gosh, I have to do all of my exposures today. I have to do them all. Otherwise something bad is going to happen. My therapist is going to be upset with me. My OCD is going to come back. I'm going to lose control. I'm going to relapse. See, like, even in my energy, right, there's like this urgency. There's like this, I have to, I need to, otherwise, ... And like, that's how we know that it's no longer in your hands. It's no longer in your control. Like, you're no longer in the driver's seat. It's not like, man, I really got to get back to my exposures, so I got to make some time for that. They're two totally different shifts, right? They're two totally different mindsets. So the first, like, giveaway to me when anything is becoming compulsive is this urgency, this need. It's not a preference, it's a need. Right? So there's a sense of urgency. There's a need there. It has to be a certain way. It's very rigid. I can't just try my best and do whatever exposures I can fit in today. I have to do all 25. I have to do all 25. And I can't, if there's a missed trial, or if I did a trial where I might have virtualized a little bit, but I'm going to go back and I'm going to do that just to be sure. So it really comes down to, like, this behavior that is also very characteristic of OCD from time to time, trying to sabotage your attempts at progress and treatment. Where the OCD just tries to make you doubt the treatment and doubt whether you did it correctly and doubt whether you're doing enough exposure work and doubt your rating for it and doubt whether you did the exposure trial the right way. My best advice for this is to just recognize when it's happening, recognize when that energy is kind of getting out of whack, like when you're starting to get more ramped up about it and you're not able to just kind of like be more flexible in your approach with it. And ask yourself, like, okay, what's my fear? Usually it's a fear of relapse, fear of losing control, fear of anxiety and like going back to that bad place, right? And that too is also something that we need to sit with. So we need to sit with the uncertainty that we could do all the exposures in the world. We could resist all the compulsions in the world and we might still relapse. We might still lose control. We might still have bad days. And we sure as heck can like stack the odds against us. We sure as heck can control some things, but we're never going to be able to control it 100%. And so my advice would be to just recognize when that's getting out of control, when it's feeling more urgent and needy like that, and try to apply exposure therapy to that. Do whatever you can to fluster the OCD's feathers. Do whatever you can to just like, I don't know if I can swear here, but just make it really mad. Make it really mad. So if the OCD is telling you that you need to do all 25 trials of your exposures, you know what? I'm going to do 12 just because that's just a random number that came to my mind, right? I'm just going to do 12. Like always be showing the OCD that you have the upper hand, that you're calling its bluff, and you can apply ERP strategies to anything that your OCD throws your way, including doubts about whether you're doing therapy correctly, doubts about whether you're going to lose control and relapse. So just having that attitude of like, I have to take what you're dishing out. Like, come on, you're going to make me try to perfect my exposures now? That's ridiculous. Let's do this. What do you think?
I love that. I love the bring it on approach. I think that kind of energy that Jenna was just modeling was so key in successful ERP therapy. And, in terms of Kendall's question, that is really common. Almost everybody I work with at some point has experienced some version of that when the OCD latches on to the therapy itself or starts to create intrusive thoughts like, what if I'm not doing the therapy correctly? Or if I don't do it this many times, then that means my anxiety won't go away. So I think Jenna identified some excellent red flags that needs, must, should, that sense of urgency about the therapy itself is a red flag that the therapy can become a compulsion in itself. No end to OCD brain's creativity. So whenever you see those red flags, that's your cue to step back, treat that as a ritual as well, and then to declare independence from it, rebel against it. It could be messing up the number, doing the exposures the wrong amount of time. It could be taking a pause and maybe not even doing any exposures for that moment and saying, look, brain, look at me living life on the edge. I'm going to not do therapy for a few hours or a day or two and maybe risk that that's going to make my OCD worse. And then having thoughts like that is also a red flag of, well, what's the end game, right? Sometimes people are really excited of like, oh my gosh, there's this therapy that's going to help me manage OCD. Maybe if I do it the right way or if I do it intensely, then I'll get rid of it and never have OCD and never have anxiety again. And that's usually a huge stuck point as well. So remember, it's not about doing the therapy the right way, but it's about really embracing the spirit of the therapy, which is showing brain that you're running the show, not the OCD part of the brain, and that the exposures are there as a way to kind of retrain the brain and practice this technique, but they can backfire if you're starting to do them in a rigid, perfectionistic way, or if you're trying to do them as a way to get out of OCD, to never have thoughts or feelings that are unwanted again.
Mm-hmm. So good. I had so many things. I was like, I need to remember to say that, but I was so like wrapped up in what you were saying. I'm going to use that more. I like the concept of like declaring independence from it. I think that's really powerful. I've always kind of viewed that as like this as diffusion, but I like the concept of declaring independence from it because it like obviously provides that separation, and it's like, nope, I'm going to do my own thing. Like I call the shots. I'm going to do my own thing. I really like that. So I'm going to steal that. Yeah, such good stuff. Oh my gosh. So hopefully that was helpful. Hopefully we got some good advice there. I love this. Anthony, I'm so glad you asked because I feel like in these webinars, like we do a really great job. This is something that we're thinking about how to improve them and just like, continuing to make sure that we have the best experience for you guys. We get into some really deep questions where like, if I had just been diagnosed a week ago and I'm hopping onto this webinar for the first time, I'd be like, whoa, what the heck are you talking about? Like you're already jumping into like the end of treatment and like maintenance and recovery. And I know that's helpful for the majority of you, but we might still have some people who could benefit from like a really simple overview of ERP. So yeah, so Anthony, thank you so much. So let's just give our simple rundown of ERP. Do you want to go first?
Sure. Yeah. So I think you're right. And I'm glad that you brought this up as well, kind of going back to the basics. I think there's different ways to explain it, but the way that I kind of explain it to people just getting started is I look at ERP as having two parts, a reactive and a proactive part. And the reactive part of ERP is really more like the response prevention, like what to do when you have an OCD episode, how to deal with those thoughts and feelings skillfully, and how to give them less power, and how not to feed into the OCD by doing some of the things that's like throwing a log on the fire, like the rituals, avoidance, reassurance seeking, etc. And then the proactive part is kind of figuring out ways to practice showing brain that you are not going to treat these false alarm signals as if they're dangerous or relevant. And sometimes that requires doing something that feels totally counterintuitive, the opposite of everything that your brain has been telling you to do to keep yourself safe, by actually kind of poking at those and going towards some of the things that might trigger the thoughts and images to really demonstrate to the brain that they're, even though they feel scary, even though it feels really, really dangerous, even though the brain might be firing, freaking out in that moment, that you're going to let those thoughts and feelings happen, to be there. And that's the exposure part as well. So both parts are really, really important, and response prevention and exposures are just different ways to be reactive and proactive to show your brain that you're going to be relating to these thoughts and feelings in a different way.
Yeah, that's awesome. I always learn so much, like different things that I'm going to take back to my members at NoCD. So this is really great. Thank you. And I'm going to try to give like a condensed version of my 60-minute intro psychoeducation in like 2 minutes. So exposure and response prevention, or ritual prevention, always ERP, is the gold standard treatment for OCD and anxiety. It is, there's nothing that even like kind of holds a candle as far as when it comes to the treatment for OCD. So what that means is that it's evidence-based. It is backed by tons of literature, tons of research. And so there's a lot of different there's two main ones, kind of models that would explain, or that attempt to explain why exposure and response prevention is so helpful for OCD and anxiety. So the first model, that's kind of the reigning model that's been around for a while, is the habituation model. The habituation model says that basically by doing these things again and again that you're afraid of, by continuously and repetitively in a prolonged fashion, approaching these exposure-like situations or these anxiety-provoking situations, you basically habituate, meaning you get used to it. So I always describe to my members the same way that when you jump into a pool, it gets really cold after a while. When you've been in that pool, you kind of get used to it. The habituation model states that as you continue to do these anxiety-provoking things, you have that physiological reaction of anxiety, and you also will get used to that. A lot of times people with OCD and anxiety, they like bail out of that peak panic. And so they don't allow themselves to naturally habituate. So they stay stuck in this like mini loop. But that's kind of like jumping out of the pool, right? Like you can't get used to the water if you're constantly jumping out of the pool. And So the habituation theory states that basically exposure works via this process of you getting used to the anxiety, you getting used to this anxiety provoking situation, and basically you're no longer perceiving threat in this previously threatening situation. Now there's also something called the inhibitory learning model that I love. That basically states the reason why exposure and response prevention is so helpful is because as you approach these anxiety provoking situations without your typical safety behaviors or your compulsions or rituals, you basically learn that you don't need to be doing these things in the first place, that your feared event isn't as probable to happen, that your feared event isn't as catastrophic as you thought that it was, that you can handle anxiety and that it does pass and that it's not going to catastrophically just increase infinitely forever. And at the end of the day, you learn, even if your feared event does happen, you learn that you can tolerate that, right? Like we've tolerated everything that we've ever been given, even if it's not with grace or with all the comfort in the world. Like we've all handled it. And so the habituation model, inhibitory learning, a lot of people are like, which one is better? I dig pieces of both of them. But that's kind of two of the models that would explain why exposure and response prevention is so helpful. Essentially, it's in order to get over it, you have to go through it type of thing. So in order to get over your fear of kids or knives or what's going to happen in the future, or what if I just don't know this answer? Did I do something awful? Could I have hit someone with my car? You put yourself in those situations that you've thought were triggering, and you try to reduce or resist the rituals that you're used to doing, and you eventually habituate, you eventually get used to it, and you learn that you're far more capable than you thought. So hopefully that was a good little overview of ERP. We also have some really good videos, like just introductory videos on ERP and why it works on our YouTube channel. So those would be really good if you want to check those out. Feels good to get back to the basics.
Yeah, and just it's hard sometimes too because we're so deep in it. And just another thought I had as you were talking is really the goal of ERP, regardless of how you practice it or what your OCD theme is to learn that you can tolerate uncertainty, because uncertainty is the hallmark feature of all types of OCD, whether it's more traditional OCD, like am I going to catch a disease from not washing my hands, or did I forget to turn the stove on, am I going to burn my house, or more of the pure O sub type of am I a pedophile, am I going to hurt somebody I care about, am I going to hurt myself, am I identify as heterosexual but I'm really homosexual. Whatever the question is, brain is sending you this false alarm signal saying you cannot tolerate uncertainty. You must know, you have to get the answer, do anything and everything to get 100% certainty. So ERP is really the opposite of that, because we know that the more the person pursues certainty, they're deeper in the rabbit hole they find themselves, and the more questions come up, right? Even people who are very logical, rational, for example, with the classic stove example, someone could be looking at their stove, see that it's off, and their OCD part of their brain might still say, oh, what if it's not? Or are you sure you're seeing it the right way? Or maybe it was a little blurry, or maybe it was off a second ago, but now it's not off. So logic and reason does not get people very far when it comes to OCD. So it's really about using exposure and response prevention therapy as different creative ways to practice building up that threshold for being more okay with not knowing, even though it might feel very uncomfortable, especially at first.
Yeah, I like that you brought that up. Like you can't logic your way out of OCD. I was just doing a support group earlier today for an OCD, and we had talked about this as like, I've been challenging my thoughts and it just works for a little bit, but it doesn't actually end up working. Like, why can't I just, it's so maddening because I know better, but I just can't do it. And it's like, that's the maddening part of OCD, right? Like that it is so illogical that you've looked at your stove 100 times, but you still feel like you need to. And that's what can really distress people and, drive them crazy, it feels like. So yeah, I like that you mentioned that, because you can't logic your way out of this. Like you have to truly do the exposures. You have to feel the feelings and resist the rituals anyway. Like it's going to feel irresponsible. It's going to feel bad. It is going to feel potentially, you're going to feel maybe guilty. You're going to feel anxious. You're going to feel uncertain, but resist those rituals anyway. The behavior change has to come first. And then eventually you'll feel that that logic does make a little bit more sense later. But really the behaviors have to come first. And yes, Anthony, these will be recorded. These are all recorded either, well, they're recorded both on our Facebook page and our YouTube page. So this is going to be recorded for you to access again. I like this question because I don't really know 100%. So I really want your feedback, but I'm just going to wing it and give you my spiel, like what I think. So Josh, I feel like I have had OCD tendencies for most of my life. I'm 22, but my first ever episode started 6 months ago from the pandemic. Do most people with OCD have one particularly hard onset episode? So one of my big areas of interest is generalized anxiety disorder versus OCD. That's become an increasingly interesting topic that I love because I always felt like there was so much overlap. And I thought that maybe I was the only one who thought that way. But then when I asked a bunch of my other OCD nerd friends, I realized that we all think kind of the same way. And like, wow, this is actually really similar. Like, are there really any that big of functional differences in the first place? But moral of the story, Josh, I think you're in good company, unfortunately. I think a lot of people have had OCD tendencies when they look back for most of their life. I feel like most of the people who I've ever worked with in the past 12 years would always be able to say like, well, my childhood makes so much sense now. Like now that I have this diagnosis and now that it's like obvious and in my face, I feel like I've always been this way. But all that is to say, one differentiating factor that I've come to find both professionally, clinically, and the research when it comes to the differences between like GAD, generalized anxiety disorder, and OCD is that generalized anxiety disorder does tend to be like more gradual onset. It kind of is insidious like that, just like this gradual onset. But OCD has been reported more times than not to be like this slap in the face. Like it's just a slap in the face and it kind of hits you. And there might have been some tendencies like throughout the rest of your life for sure, but like it just happens. Like it's a slap in the face type of situation. I remember like I've been open about my own personal lived experience with OCD. I remember the first intrusive thought I had after I had my son. He was about a month or so old. I remember I went to go put socks on him. I remember flashbulb memory. I remember he was in my bed. And I think my husband was there, but I was putting his sock on. They were little teeny tiny blue socks. And I had the intrusive thought, like, what if you just lose control and you snap his ankle? And for a year, I didn't put socks on him. Even though I knew I should not be doing that, I should not be giving into that. Totally did. Because I felt it, like the stakes were just too high. So yeah, I mean, it just can kind of slap you right in the face. I think that OCD in general is complex. People are complex. People all have different experiences, but I definitely have heard so many times that yes, exactly what you're saying here, Josh, that people have been diagnosed with it. They feel like they've kind of always been that way, but maybe they've been diagnosed with generalized anxiety disorder. They were always just kind of an anxious person, but now they're struggling with really high alarm, very specific intrusive thoughts, potentially had a really big episode or like a really kind of slap in the face trigger that happened. And also wouldn't be surprised if the pandemic kind of like set a lot of that off because the pandemic has been terrible for all of us. So I don't know if I have an answer as far as like, do most people, but I hear it all the time. So professionally, I would say that this is exactly what I hear all the time. What do you think?
Yeah, no, I think it's a really interesting question. I'd actually be curious to see what the data says about that. I think in my personal clinical experience, it's really been a mixed bag. There's definitely been a lot of people who are able to identify that kind of flashbulb memory, as you called it, where there's this one episode where they're doing something. They might be just chopping up some vegetables in the kitchen the way that they typically do. And then their, spouse comes up and says, oh, do you need any help? And then they might have a random intrusive thought of, what if I just take this knife and stab him through it, and that could perpetuate. And if they give relevance to that thought, or put the knife down, or step back, or try to remind themselves, I would never do that, or ask their spouse for reassurance, like I've never done anything to indicate that, right? That can then perpetuate a big cycle of OCD. So for some people, it is just a random occurrence that happens suddenly and goes from 0 to 100 really quickly. For a lot of people, even though OCD is not caused by trauma or stress, but for some people who have a biological predisposition to it, a big life change or stressor, which the pandemic has been for most of us, can definitely make people more vulnerable to it. And sometimes even like a positive change, like having a baby, moving to a new house, getting a new job, things, a wedding, things that people might like and be excited about might also make them more vulnerable to OCD popping up. And then for other people, it's just kind of gradual, that they might have had little tendencies here and there. And sure, if they might have thought this was just like a quirk, and like, yeah, sure, I'll just check the stove one more time or two more times, no big deal. Or I'll just make sure to step further away from the subway tracks just in case, because I've had a thought I could hurt someone. And then the more they give those thoughts power by avoiding doing things that might put themselves at risk, then slowly but surely the OCD part of the brain starts coming up with more and more creative ways to try to keep the person safe, quote unquote, with the false alarm signal. So kind of in short, seen it a lot of different ways. And I think less important than what the onset is, but more important to recognize the red flags and to try to get the tools to handle them sooner than later.
Mm-hmm. Yeah, seems there's so much snowballing can happen, right? So I had this conversation today too about generalizing, right? So there's a term in the ERP world called generalization. So hypothetically, if someone came in and they were fearful of a white rabbit, we could do exposures with white cotton balls, white dogs, white cats. And even if you never had any exposure to a white rabbit, at the end of the day, you would still be less fearful of a white rabbit because you generalized via exposure work to things that are also white and cute and fluffy and cuddly. But it also works the opposite way. So fear also generalizes. So that's what you're talking about, it seems like, right? Like this is how the OCD can make your world smaller and smaller and smaller depending on how you approach it, depending on how you react to it and how much like give you give it. So let's say that you are fearful of a white rabbit and you don't do those exposures and you're not being proactive or kind of reactive by resisting rituals, right? Like you are going to eventually be afraid of a white dog. You are eventually going to be fearful of white cats. That will branch out and your OCD is going to kind of stake its claim on more and more things. So yeah, just always comes back to ERP, always comes back to just like you said, reining it in, identifying kind of those red flags and applying what you know about ERP to those scenarios for sure. I don't know why I do this, but I like always go for the tough questions that like I don't know how to answer 100%. So I think this is a really great question. Rachel, can you explain why it feels like you're just avoiding and distracting yourself when you're resisting compulsions? Mine are all mental compulsions. I've completed treatment, but I still have those days and weeks when it seems like it's back to square one, even though I know that's not true. So I have experienced this like personally myself. Like, am I sure I'm actually resisting a ritual right now? Or am I just avoiding and like distracting myself? And I think the ticket is having the attitude of that thought can either be there or it cannot be there. I'm ambivalent to that. Like it can either be there or it cannot be there, but I'm still going to go and do whatever it is that I want to do. Adopting that attitude as much as possible has helped so many of my members and has helped me. When it comes to, am I resisting the ritual or am I just kind of distracting or am I not? Like, I think that can get really blurry and kind of confusing for people. And so I understand the confusion for sure. But having the attitude of like, that can either be there or it cannot be there. I don't know, but I'm still going to move forward with whatever it was that I wanted to do anyway. I'm just thinking back to like all of my triggers that I've had or all of the members who I meet with at NoCD. And like, that's the ultimate attitude. for sure, is just like, whatever you're going to do is whatever you're going to do. You can hang out in the background. That's totally fine. You can shut it down. You can keep talking. Like, it's okay. Whatever you want to do. But again, back to what you said, Tatyana, which is like, I declare independence from that. I'm still going to go and do whatever it was that I wanted to do. What do you think?
Exactly. This is a great question because I get this question all the time because there's such a fine line between kind of distracting, avoiding, and then being skillful and giving it irrelevance. So the word that comes to mind when we're thinking more of the skillful part of the spectrum is mindfulness, right? So the difference is when we're distracting, we're like, don't think about that, don't think about that, think about anything else, don't think about that, versus mindfulness, which is more of the spirit of I'm going to focus on being in the here and now. I'm going to notice any thoughts, the feelings come up, wanted, unwanted. I'm going to let go of all the judgment of them. Like Jenna was saying, give them permission to be there and then refocus on living my life. I think sometimes like using imagery or metaphor helps for some of these things, like even something as simple as like you're in a room and there's a bee or a fly kind of buzzing around and it's really annoying and it's really distracting and you just spent 20 minutes kind of running around the house trying to swat this bee, trying to get it out, trying to open the windows, shoo it away. And then you just realize that you have just spent a lot of time and energy trying to get rid of this fly, unsuccessful, taking a time out from living your life, doing what you want to be doing. So eventually it's about kind of making the decision of like, I didn't invite this insect into my home. It's kind of annoying. It's kind of distracting, but you know what? I've got important things to do. So I'm going to refocus my attention on what I'd be doing if this insect wasn't here. And sometimes it's just going to be in the background noise. Sometimes it might kind of fly in front of my face, make a noise, be distracting. But you know what? I'm not going to spend another second trying to swat it away or running after it. I'm just going to sit here, do my thing, and let it do its thing. And I don't have to like it. I don't have to invite it in. But the more I give it permission to do its thing while I refocus on living my life, that's the true path of freedom. So again, it's about not judging the thoughts or feelings as good or bad. It's about giving them permission to be there. And then instead of trying to control them, controlling your attention instead and continuing to bring your attention to the things that actually matter to you.
Right. And the term distraction here, I think there's good and permissible distraction versus compulsive and bad distraction, right? So I think sometimes I worked with this a lot in residential where like the term sit with it. They literally thought sometimes that they had to like legit stop the world around them and sit with it. And it happened so many times. That was either OCD just taking things super literally, but it was also like, I get it. And you can't expect the world to operate under that form, right? Like you can't always just, anytime you're triggered, just stop the world around you and take that moment to sit with it really. And like totally give it your 100%, kind of focus and attention. So I get a lot of questions sometimes about like, well, how do I, like, what's good distraction? What's bad distraction? So to me, bad distraction is, I don't want to think about this. I have to go and do this instead. I don't want to think about this. Otherwise, something bad is going to happen. I can't keep thinking about these images. I just need to get these images out of my head. So I need to go and think about this instead. That's bad distraction for me. That's compulsive. That's aimed at trying to reduce the fear that you're experiencing as the result of an obsession. And so that's not good. Distracting in that sense is the same as washing your hands or checking or asking for reassurance or hopping on Google and analyzing. It works the same as any other compulsive behavior. Good distraction, or what I would call just moving on with the rest of your regularly scheduled programming, is just that, right? So, being able to be triggered and then, I recognize that as an obsession. I'm not going to answer that question, and going back to work because that's what you need to be doing. That to me isn't distraction. That to me is just moving on with your life. That to me is kind of taking that with you. And again, having this attitude of that thought can either be there or it cannot be there. That fly can be swinging around me. I'll get, maybe I'll get to it. Maybe I won't, but I have stuff that I need to do and I'm going to make sure that I get that done because it means a lot to me. And I always tell my members, like, you can resist a compulsion, even a mental one, and do something at the same time. Like, you can do your work. You can watch a movie with your friends. You can take care of your baby while resisting a ritual. while not engaging in rumination, while not answering this question. So, you know, you don't always have to be just like in total like Zen mode where you're focusing on resisting your rituals and all that. You do have permission to just move on with the rest of your day while you're resisting your rituals. So again, it's always going to come back to, are your values dictating your decisions over your fear? Values over fear.
Yeah, and I think another kind of just shorthand way to ask yourself that question is like, is this a towards move or away move? Am I moving towards my values or away from the discomfort of having this thought and feeling? And just another question to ask yourself is like, what would I be doing if I didn't have this intrusive thought or feeling right now? And that's kind of a cue of like, come back to living your life. I'd be watching a movie. I'd be hanging out with my friend. I'd be having my pillow lay on my head and noticing how it feels. And that's your cue to come back to the life that you are living versus trying to answer the $1 million what if ... question that OCD brain might present.
That's good for indecision too. So if you're really struggling with a decision, or should I do this or should I not do this? Should I be washing my hands right now? Should I not be washing my hands right now? Be asking yourself, like, what would I do if anxiety and OCD wasn't part of the equation? And for the most part, people know, right? Like for the most part, people know.
Most of the time, I think people are able to answer that question. But if they're not and they get stuck and that becomes a new obsession, I would say flip a coin.
Yeah. Bring a coin. We got to use the coin sometimes. Got to break out that coin. Another awesome topic area. So any knowledge about OCD brought on by pregnancy and delivery. So Tatyana, you were already mentioning, which I love, this concept that like nothing causes trauma or nothing causes OCD. So this concept, I hear it sometimes, that like my trauma caused OCD, or, you know, my upbringing caused OCD. And it's really important to understand that we're born, if you have it, you know, this genetic predisposition, and certain life events or an event can kind of influence the light switch turning on or off. But it's never just one thing, right? So one of those things that kind of like determines whether that light switch goes on or off could be pregnancy/delivery, right? So not only is it this huge, significant life change that affects so many areas of your life. You know, Tatyana and I both have kids, so we've been there. I have a 3-year-old and Tatyana has a 16-month-old. And I mean, your identity changes, your financial situation changes, your romantic partnership changes, how you spend your time changes, everything about you can change. And that's not even talking about the hormonal, like physiological changes that pregnancy and delivery just can completely wreak havoc on your body, right? So huge potential here, especially if you've had OCD tendencies in the past, especially if you have a history of an anxiety disorder or any kind of related or mood disorder. If you have anyone in your family who has struggled with anxiety, OCD, depression, anything like that, then it can be kind of like this mixing pot of potential for symptoms to show. So OCD can definitely come up during pregnancy. It can come up after pregnancy, really at any point. So I think there's this misconception that if I am not anxious and depressed and obsessive and compulsive, if I feel those things after a month, or if I feel those things after 6 months, then it's not postpartum OCD or it's not postpartum depression. That somehow those things can only happen within like the first 2 weeks of you having your baby. And that's just not true. It can happen at any time, especially with changes in breastfeeding as well. So a lot of women, like when they stop breastfeeding, they can experience a lot of physiological changes and hormonal changes, also just like emotional changes as well. So yes. Oh my gosh. So the big overwhelming answer is yes, it can certainly come on in pregnancy. There are a million reasons why that happens. Can happen during delivery, can happen after you have birth or have a baby. But the 3 things that I always try to like normalize for parents is OCD hates uncertainty. OCD hates anything that is uncertain, right? So if you have a brain that hates uncertainty, which anyone who has OCD does, right? We hate uncertainty. We want to be 100% sure. OCD, like what is more uncertain than having a baby or like being pregnant or embarking on this journey of parenthood, right? Like there's this vulnerable baby, you don't know much about them, they're in your belly. Then there's so much uncertainty associated with labor and delivery. There's so much uncertainty associated with having the baby and taking care of a newborn. They can't talk, they can't tell you what they need. So it's no wonder OCD latches onto that, right? So OCD hates uncertainty. OCD also hates anything or latches onto anything that you value, right? So, your job, your romantic partner, your animals, your goals, the good times in your life. Of course, OCD is going to try to latch onto when you have a baby. That's like what we value most, right? So we have uncertainty against us, we have values against us, and the third, like triple whammy that I always tell for moms or parents in general is that OCD hates anything and latches onto anything that's vulnerable. So there's actually something called the Arnold Schwarzenegger effect, which is referencing this concept that no one has harm intrusive thoughts about Arnold Schwarzenegger. So we don't experience that because Arnold Schwarzenegger is a pretty tough guy, right? Like if any of us were to go after Arnold Schwarzenegger with a cold hard punch or like impulsively lose our sense of control and just like stab him, right? Like he would probably kick our butts. A little baby isn't going to be able to do that, right? So OCD tends to attach itself and get really, really freaked out about anything that's vulnerable. So dogs, elderly individuals, pregnant people who are sick, babies, kids, okay? And so there you go. It's the triple whammy. Things that are uncertain. What's more uncertain than having a baby and being pregnant and being responsible for that baby? The next kind of hit there is OCD latches onto anything that we feel really responsible for. And then uncertainty, responsibility, and values. That's parenthood. So those are all the reasons why this can happen.
Yeah, no, I love this question. This is actually one of my areas of passion and interest. I think there's a lot more awareness these days about postpartum depression, but definitely not. We're starting to get there, but definitely we still have a really long way to go in bringing awareness to this very topic. And postpartum and during pregnancy, just the whole perinatal period is a huge vulnerability time for women to experience anxiety in general, but particularly OCD. And I think Jenna did an amazing job of really going through all of the complexities and all of the reasons why it is a perfect storm, just a minefield of that. Both a lot of physiological, biological changes happening to women. And as we talked even earlier in this talk, that big life changes are generally a vulnerability time for OCD brain to pop up or to become louder for people who already have it. And this is probably one of the biggest life changes that people can experience. And we know that biology plays a role in it, but we know it's not the whole story because we know that even men who aren't going through the same biological experiences of kind of giving birth or breastfeeding also are more vulnerable to OCD symptoms during this time in life as well. And yeah, this is a very high stakes situation for a lot of people, even people who don't have OCD or anxiety. They're generally very, very invested in trying to do this well, trying to keep their child safe. And especially when the OCD part of the brain kind of latches onto that and wants 100% certainty, it can be kind of a minefield as well. And I think just being proactive, being aware that that might happen is really important. And I think, as we were talking about earlier, trying to get resources sooner than later. Oftentimes when people have a baby, their minds become really preoccupied with the baby and they kind of forget to take care of themselves. Sometimes their physical health, like just taking a shower or eating, just some of the life basics, but especially their mental health. And I think taking a moment to note that, to get that assessed, to get that treated is really an investment for your mental health, but also to become a better parent for the child as well.
Yeah, for sure. Something else too that I always bring up is I feel like when I work with individuals who like they're just experiencing their first OCD episode, like during pregnancy, they kind of, not saying that you do, Maylene, but sometimes they have this tendency to say things like, oh, well, as soon as the baby's here, it's going to be fine. And it's like, oh, no. Like as soon as the baby's here, you're going to have a million just different things to worry about, like the temperature in the room. Are they breathing? Are they comfortable? Am I feeding them well? Could I snap his ankles when I put on his socks, right? Like, it's important, like Tatyana said, I always say now in hindsight, I waited 1.5 years to get into my own therapy. And that was like, in hindsight, I wish I would have done that so much earlier. Like, I wish I would have just done myself and my family the service of being able to do that sooner. But I remember telling my husband, like, yeah, if I had time for a therapist, I would shower instead, right? Like Tatyana said, as soon as you become a mom, as soon as you become a parent, you're going to have a million excuses, not excuses, but you're going to have a million legitimate reasons as to why you can't make that appointment or why you shouldn't. I always tell people, like, my best advice for moms is, like, make the appointment ahead of time. Make the appointment, get it all together, like 4 weeks out or 2 weeks out or whatever you think is manageable for you. And if you don't need it, then you don't need it, but at least you have it. Yeah, if I could do it all over again, that's what I would have done for myself. We also, OCD offers free support groups now. So we also have a moms with OCD support group. We offer, I think, 2 separate times. So go ahead and you can go to www.treatmyocd.com/support-groups. I'll make sure that I post it in the Facebook and in the YouTube comment section so you guys can access that. But we have tons of different support groups, including, like I said, 2 for moms who have OCD. And even if you're pregnant, you can still go. Even if you're not a mom yet, you can still go.
I love that. And OCD in general could be a very lonely, isolating experience, but especially during the pregnancy, postpartum. So I think it's amazing to have a resource to know that you're not the only one going through it. And, you know, huge reassurance alert, but intrusive thoughts are super, super common during pregnancy, particularly ones that related to hurting your child.
If anyone wants reassurance from me, tell me that you have postpartum OCD or like perinatal OCD. And just like you did, Tatyana, I'm just always so much softer with moms. I think because I'm a mom and because our mental health system is so awful when it comes to moms. Yeah, like you said, I think we're getting a little bit better when it comes to anxiety and OCD. We talk decently about depression. We maybe talk about anxiety a little bit. We maybe talk about OCD, but not a lot, right? So definitely finding other parents who you can talk about non-judgmentally. I guarantee you, if you start to open up and say some of these thoughts, you will be greeted by a bunch of other parents who say, oh my gosh, me too. Oh my gosh, me too. But no one will say it first.
Exactly. I think shame is a word that kind of comes up for me when we talk about this. I think a lot of women feel immense amount of shame. Like, how can I tell people I've had thoughts about stabbing my child or molesting my child? Like, what kind of mom am I? And because of that, they start judging themselves and isolating even more. But there's other people out there. These are just thoughts. They're super common. And the more important thing is we've come a really long way in knowing what kind of effective therapy is out there to get freedom from these thoughts and then come back to the kind of parent you want to be and time that you want to spend with your child and being able to put their sock on freely.
Yeah. Oh my gosh. No problems here. Put socks, but I have to put socks on all the time. That's like a rule in our house that I have to put the socks on. I have to put the socks on. So yes.
That exposure opportunity.
Yeah, absolutely. Well, I wish we could, there's so many questions that I would love to go through, but we're kind of wrapping up here. I want to make sure that, Tatyana, you give everyone a chance to everyone has a chance to kind of learn more about you if they want to stay up to date with you, maybe drop your Instagram so they can keep up to date with you. I would love to have you back. I'd love to maybe do some more lives and just keep in touch because you're so awesome at what you do. So yeah, why don't you tell us a little bit more about where people can find you and stay up to date with you and your work?
Sure, absolutely. So we have a website, cbtforbetterliving.com. So CBT for cognitive behavioral therapy. And my Instagram handle is OCD Anxiety Expert. You can follow me there. And thank you so much, Jenna, for inviting me. This was awesome to chat as always.
Yeah, this was really fun. Yeah, you guys had really great questions. We have webinars for the rest of the week, Tuesday, Wednesday, Thursday. I'll actually be back on Wednesday with Dr. McGrath. So come if we didn't get your questions answered, come on Wednesday. Maybe we can try to get them answered with Dr. McGrath. Otherwise, Tatyana, thank you so much. This was super, super fun. Thank you. We appreciate you so much.
Thank you. My pleasure.
Bye.
Yeah. Bye.